Good morning, everyone. I am Rasan Majalati Naval, a fourth-year medical student of the Davao Medical School Foundation. Today, I am going to discuss the anatomy of the eye. This is a longitudinal cut of the eye. The anteriormost portion is the cornea. The cornea is a transparent tissue that is about 11.5 millimeters. It has 5 distinct layers: the epithelium, the Bowman's layer, the stroma, the Descemet's membrane, and the endothelium. The function of the cornea contributes between 65 to 80% of the eye's total focusing power. Behind that is the anterior chamber. It is filled with aqueous humor, which is a clear liquid of about 250 microliters and is produced at about 2.5 microliters per minute. Its composition is similar to that of plasma, but has higher concentrations of ascorbate, pyruvate, and lactate, and has lower concentrations of protein, urea, and glucose. This is the iris. Aside from giving the color of the eye, it also controls the amount of light entering the eye. It is a shallow cone pointing anteriorly with a central situated aperture. This aperture is the pupil. It is the opening of the eye, which function is to allow light to enter, so it can be focused on the retina to begin the process of sight. Pupillary size is principally determined by a balance between constriction due to parasympathetic activity transmitted via the third cranial nerve and dilation due to sympathetic activity. This is the Canal of Schlem. The Canal of Schlem, or the Scleral venous sinus, is a circular canal found within the posterior part of the cornea-scleral junction. Its function is to collect the aqueous humor from the anterior chamber and deliver it to the veins of the eyeball. An obstruction in aqueous humor outflow plays an important role in the pathophysiology of glaucoma. The posterior chamber is found behind the iris and in front of the lens. Like the anterior chamber, it is also filled with aqueous. This is the lens. The lens is a biconvex, avascular, colorless, and almost completely transparent structure, about 4 millimeters thick and 9 millimeters in diameter. Although the cornea contributes majority of the refraction, the lens's main optical function is to fine-tune the focusing of light onto the retina. In patients with cataract, the lens are removed and in most cases are replaced with an artificial lens. These are the suspensory ligaments of the lens. The suspensory ligament of the lens, or the zonular fibers, is composed mainly of elastin microfibrils that anchor the equator of the lens to the ciliary body and suspends the lens in place. This is the ciliary body. The ciliary body is composed of the ciliary muscle and the ciliary epithelium. It extends forward from the anterior end of the choroid to the root of the iris. This is the ora serrata. The ora serrata is a peripheral termination of the retina and lies approximately 5 millimeters anterior to the equator of the eye. It is a serrated junction between the retina and the ciliary body. This junction marks a transition from the simple non-photosensitive area of the retina to the complex multi-layered photosensitive region. This is the retina. The retina is a thin layer of tissue that lines the back of the eye on the inside. It is located near the optic nerve. Its purpose is to receive light that the lens has focused, convert the light into neural signals, and send these signals to the brain for visual recognition. These are the layers of the retina. From inner to outer, inner limiting membrane, nerve fiber layer, ganglion cell layer, inner plexiform layer, inner nuclear layer of bipolar, amacrine, and horizontal cell bodies, outer plexiform layer, outer nuclear layer, external limiting membrane, photoreceptor layer of rods and cones, inner and outer segments, and retinal pigment epithelium. This is the choroid. The choroid is the posterior segment of the uveal tract. It is bounded internally by Bruch's membrane and externally by the sclera. It supplies the outer retina with nutrients and maintains the temperature and volume of the eye. Its circulation accounts for 85% of the total blood flow in the eye. It is a high-flow system with relatively low oxygen content. This is the sclera. The sclera is a tough, opaque outer layer of the eye that provides its protection and structural integrity. It is relatively avascular and in adults appears white externally. Posteriorly, it fuses with the sheath of the optic nerve. This is the superior rectus muscle, and this is the inferior rectus muscle. The rectus muscles are extraocular muscles that serve to move the eyes within the orbit. It includes the superior rectus, inferior rectus, medial rectus, and lateral rectus. These four muscles all arise from the connective tissue ring called the common tendinous ring or annulus of Zinn. This is the central fovea of the macula lutea. The vitreous body or hyaloid. It is one of the most delicate connective tissues in the body. It is a fibrillar meshwork of extracellular matrix that fills the vitreous cavity of the eye. The body is a clear, jelly-like substance composed mainly of water and delicate collagenous network associated with hyaluronic acid. The vitreous body normally maintains adhesions to the vitreous base, optic disc, major vessels, and the macula. These are the retinal arteries and veins. This is the central retinal artery, and this is the central retinal vein. The optic nerve is approximately 30 millimeters long and is mainly composed of myelinated nerve fibers or axons. It connects the eye to the brain. And this is the optic disc. The optic disc or optic nerve head is a site where ganglion cell axons accumulate and exit the eye. There are no light-sensitive rods or cones to respond to light stimulus at this point and causes a break in the visual field called the blind spot. Hi, I am Rosanna Majalati Naval, a fourth-year medical student of the Davao Medical School Foundation. And this is the anatomy of the external eye. This is the eyebrow. These are the eyelids. These are the lashes. And over here are the lacrimal puncta. Now I'm going to perform the fundoscopic exam on this eye. According to the Bates Guide of Physical Examination History Taking, you should take off your glasses. However, I will not take mine off because of my severe astigmatism and my refractive error will make it difficult for me to see the fundi. First, I have to darken the room. And now I will switch on my ophthalmoscope and look for the beam of large round white light. There it is. Now I will turn the diopter to 0 because at this diopter, it neither converges nor diverges light. Yay! Because this is the patient's right eye, I will hold the ophthalmoscope with my right hand and use my right eye to examine. The ophthalmoscope must be firmly braced against the medial aspect of my bony orbit and I will tilt it laterally. The patient should look slightly up and above my shoulder at the point directly ahead. 15 inches away from the patient, I will come in at the 15-degree angle of the patient's line of vision. As I shine the light on the pupil, I should be able to see an orange glow or the red reflex. I will now place my free hand on the eyebrow of the patient and move in closer to locate the optic disc and to check if any sharpness or clarity of the disc outline, the color of the disc, the size of the central physiologic cup, and its comparative symmetry of the eyes. Next is to inspect the retina. I will follow the vessels peripherally and each direction to note their relative size and character of their arteriovenous crossings. I will now inspect the fovea and surrounding macula and the anterior structures. Everything looks normal. And after that, I will do the same on the other eye. And that is the eye.